Hello, this is Vic Sinise from Chicago Metro SUNA. I'm going to be recording the first 3 slides because there was a glitch with our recording system and the first 3 slides were too garbled to understand. This is on the treatment and surveillance of kidney stones, and it's a presentation by Dr. Kristen Baldea. She will be coming in after the 3rd slide where everything took nicely. So I'm going to take it over from here until we get to that point. So our objectives: choose the appropriate diagnostic imaging for kidney stones, understand the complexities of treatment timing, basic understanding of surgical options, principles of dissolution therapy, principles of medical expulsive therapy, known stone prevention resources, and understand the purpose of surveillance and when to intervene surgically for non-obstructing stones. So here's a case study. A 47-year-old male presents for an acute visit with complaints of right flank pain. The pain started the day prior and is a 7 out of 10 in severity and non-radiating. He has not tried pain medications. He does say he's nauseated, but no vomiting. He denies dysuria, hematuria, frequency, urgency, fever, or chills. He's never had pain like this before. Past medical history shows he has hypertension, hyperlipidemia, and obesity. Past surgical history, none. Social history, he's a non-smoker, construction worker. Family history, no family history of stones. Physical exam shows that he has no fever, slightly elevated blood pressure, and slightly elevated heart rate. Normal physical exam except for the pain. So what we expect is signs of renal colic, abrupt onset of unilateral pain originating in the flank, paroxysmal, nausea and vomiting common due to common innervation of kidney, stomach, and small intestines. Plus or minus on whether you'll have hematuria. The location of the pain may reflect the site of obstruction: UPJ, proximal ureter, flank pain; mid-ureter, lower abdominal pain; distal ureter, irritative LUTs, groin pain; pain caused by obstruction, inflammation, and infection.
So non-obstructing stones in the absence of infection typically do not cause pain. Now, this is a little bit controversial. So the idea of and we're going to go a little more into how pain works with renal colic, but the idea is that, sure, if you have an infection, you have inflammation, that can cause pain. If you have hydronephrosis, you have stretch of the kidney, and that's going to cause pain. But what about those non-obstructing stones? Do they cause pain? Well, I never tell a patient that your stone is not causing your pain. All I tell them, because there are some small studies, not well done studies, but there are some showing relief of flank pain by removing non-obstructing stones. So I tell them that I cannot guarantee you that this pain is from your stone, and I'd be happy to take your stone out to see if it gets better, but me and you need to understand that there's a good possibility that your pain will remain. So if it's not from the stone for flank pain, what else could it be? Well, obviously, if they have hydronephrosis, it could be the stones, but it could be stricture, UPJ obstruction, or malignancy. Just pyelo will cause flank pain, renal infarct, retroperitoneal hematoma. I mean, these are all things you're going to pick up on imaging anyway. Aortic aneurysms, cholecystitis, diverticulitis can mimic flank pain. The last 3 are the 3 that I think are most interesting. And I think we tend to forget about these on the differential for flank pain. Costochondritis, spinal disc disease, and psoas spasm or muscle spasm. Those are the 3 that really aren't typically diagnosed on our standard imaging. So when you have a patient with flank pain and it's not from the stone, or it's a prior stone former and they're convinced it's a stone, but you're seeing nothing on the imaging, this is where my mind goes to tell them about these possibilities. And then, we don't really manage this. I typically send them back to their PCP and maybe alert the PCP that I'm thinking it could be something like this. Or occasionally, if it seems really clearly muscular to me, I'll do the physical therapy referral myself and send them to PT for flank pain. So how does pain work during an acute stone episode? It starts with obstruction of urinary flow. Then you get increased wall tension in the urinary tract and rising pressure in the renal pelvis. This then stimulates the synthesis and release of prostaglandins, and the prostaglandins is the most key thing about this pathway. Prostaglandins then cause vasodilation, which causes diuresis, which puts more urine in the kidney and increases the intrarenal pressure even more and causes more pain. So you have to, if you're going to treat renal colic pain, you have to stop this process. So how do we do that? NSAIDs work great against prostaglandins. Also prostaglandins also have a mechanism of causing smooth muscle in the ureter to spasm, causing the obstruction to be even worse. So it's just multiple pathways by where the prostaglandins are causing pain. So NSAIDs work directly on prostaglandin release. So we would think, theoretically, that NSAIDs should be your first line of pain management. Well, does that play out in studies? Yes, it does. There was a systematic review looking at pain management for renal colic in the acute setting. They looked at all the studies that had NSAIDs, acetaminophen, and opioids. And they found that NSAIDs are at least equivalent to opioids, and they were at least the same, and in a lot of cases better when looking at the studies, and the same of acetaminophen, at least the same or better for relief of pain at 30 minutes after given the medication. They also saw less vomiting with NSAIDs compared to opioids, and less rescue analgesia with NSAIDs compared to acetaminophen. So the bottom line from this systematic review is that NSAIDs should be the preferred analgesic option when a patient comes in acutely with renal colic. So I cite this study a lot to patients who are kind of opioid seekers or really saying there's no way Motrin's going to work for me, or Toradol is great too. I tell them, well, actually, there's a lot of great studies, and it's because kidney pain is different than other pain, and this we really need. Do they maybe need narcotics too at some point? Yeah, sometimes stone pain is bad enough for sure to need it, but they need to be on baseline NSAID, assuming they can take them and they don't have contraindications, and then use the opioids for breakthrough. All right, back to our case. So basic lab workup for acute presentation of renal colic is going to be a urine dip or urinalysis. This guy doesn't have any infection, but he's got some hematuria, a CBC, and a BMP. His white count's 12, and his BMP looks good. Creatinine's a little high, but normal, 1.2. So microscopic hematuria is very suggestive of a stone episode, but up to 18% of people can have stones and have no hematuria. So you can't use it to rule it out, but if it's there, it's very suggestive. High urea, so leukocytes being positive, is very, of course, going to be concerning for infection, but you can have pyuria just from the inflammation from the stone. So white cells or leukocytes in the UA don't definitely mean they have an infection. Nitrate positive, though, is very concerning. Nitrate doesn't turn positive just from inflammation. That really turns positive from gram-negative bacteria. So that's going to really make you think there's definitely an infection. Otherwise, you kind of have to look at the whole clinical picture. Again, kind of like the pyuria, leukocytosis is common too. There's a stress response to the obstructing stone. And so a low-grade leukocytosis, like a white count of 12, we see all the time. That's kind of expected. That also doesn't concern me. But if you get up 15 or higher, it starts to get a lot more concerning that they have a true urinary tract infection or pyelonephritis. And then you're going to be looking also at the creatinine for acute kidney injury. You can see an AKI in the setting of an obstructing stone for a number of reasons. Patient could be dehydrated. They could have a bilateral stone. You could have a unilateral stone and they have renal insufficiency, or obviously obstruction in a solitary kidney. Theoretically, if you have two healthy kidneys and one is obstructed, you shouldn't really see much of a change in the creatinine because the other kidney can do all of the work. But you might see a slight bump still. So in summary, now we have this non-toxic patient. He's got renal colic, microhematuria, and we're very concerned for an obstructing stone. So now we need to send him for imaging, and we have to decide what we're going to order. We have three options: renal ultrasound, KUB, or CT. And if you're looking for stones, you're going to want a non-contrast low-dose CT, and I will show you why. So ultrasound is really useful for a screening test. I use ultrasound when my suspicion is low. They don't have a prior history of stones. I have suspicion of musculoskeletal pain. They don't have hematuria. Someone like that is a great person to send for ultrasound because it's no radiation, it's cheaper than the other imaging. It's also going to be your first line test in pregnant women, and in the pediatric population, The downside is you don't actually visualize the ureteral stones, you just see the hydronephrosis, but then you would know then to get the CAT scan. Ultrasound, also when you're following stones on ultrasound, you need to know that it really tends to overestimate the size of stone by several millimeters, and also can show stone when there is no stone. It's pretty uncommon to go the other way around where it misses stones unless they're really tiny, but I've had so many times where, you know, it's like stones 1 centimeter on ultrasound and then the CAT scan is 4 millimeters. That's so common. So you have to follow that up after ultrasound. Very technician dependent, and you have to get cross-sectional imaging if you're thinking they're going to go to the OR. That comes from the AUA guidelines, because we should have non-contrast CT scan basically in anyone having surgery. What about KUB? KUB really has a pretty limited role, but it can be very useful to follow stone passage. So I like to use KUB if somebody is in the ER or in your clinic and you know they have a stone and you're going to try to send them home for passage. I might send them for a KUB because if I can see it on that, it's useful and follow up to make sure it passed. A KUB is anywhere from 1/20th to 1/50th the radiation of a CT scan, depending on your CT scan dose. So it's a lot less radiation. So it's very useful if you know you can see it on KUB to follow it up later. So a lot of times if we're sending someone home from the ER to pass a stone, we'll get a KUB before they go so we can have it in the future. It's very limited though. If you have a very obese patient, phleboliths, you know, the calcifications in veins will mimic stones in the pelvis. Can be very difficult to tell the difference if it's in the ureter or not. Uric acid stones do not show up on KUB. Constipated patients, they just have a lot of bowel gas, can obscure things. And they have to be around like 3-4 millimeters at least to see it. Like 3 millimeters in a skinny patient and a bigger patient, like you might not see it at all, but at least 4. So it does have pretty limited use. Non-contrast CT is going to be your imaging modality of choice. There's been many studies showing that it is by far the best imaging modality for looking at renal colic because it's extremely sensitive and specific. It's not going to miss it. If it's not there, you know, or if it's there, it's there. And the other benefit of CT is that it may identify an alternative diagnosis up to 10% of the time. So at least you know you're not missing something else as well. And then more recently, there's been a lot of push for low-dose CT. And if you're really just looking at renal colic, low-dose CT is perfect. Our order for a CT stone at Loyola is protocoled as a low-dose CT. So that I don't know if it's that way at all institutions, but if it's not, something you should be writing in the comments or asking for. It does not, you lose almost nothing in accuracy by going to low-dose, and it's way less radiation, like 10 times less. And you really only benefit. The only time you might want to not get a low dose is a very large patient, so like 300 pounds or more, you're going to start to lose the resolution on low dose. Okay, so our patient, we got a CAT scan, and we got a little bit of mild right hydro, and then a stone down in the distal ureter, 4 millimeter stone. Okay, so our patient is non-toxic, renal colic, hematuria, CT of findings of 4 millimeter distal ureteral stone. What do we do with this guy? Do we have to treat him right now? Can we treat him next week? Or can he come next month? When do you want to send the patient to the ER, or if you know, he's in your clinic to the OR, whatever, you know, your workflow is, or at least to admission? If the patient is infected, for sure, they don't go home. Acute kidney injury, that's going to need to be monitored or intervened on. One that's a little more relative, severe pain not controlled by oral analgesics, that one's up to the patient. That's their factor that they decide. And inability to tolerate PO, in order to pass stone, you got to be able to drink a ton of water. So if you're vomiting, can't go home. Or any complicating factors, so such as immunocompromised patients, transplant patients, someone with really poorly controlled diabetes, anyone who's really high risk for development of infection in the setting of obstruction, you may want to monitor. in the hospital for 24 hours at least. A solitary kidney, a little bit of a relative one, if it's a really small stone and they're really reliable and they're not infected, like maybe you could let them stay outpatient, but most of the time you're going to be watching them in-house. And anyone with bilateral obstruction, because they could go into renal failure. When can you wait? A week or two. That's again the relative one with the pain. Depends how bad the pain is, right? The pain's horrible. You need to do it right then and that day. You might have to, but sometimes they can kind of get by, wait a week or so, get into the OR schedule a little more electively. Anyone who has prolonged unilateral obstruction or multiple ED visits for the same stone, I hate to see people bouncing back. My rule is if the patient came back to the ER a second time, I don't want them going home again. They got to be admitted and added on. They're just going to come back again. Or if they have a really low likelihood of spontaneous passage. So I have a table here from a New England Journal of Medicine paper back in 2004 looking at stone passage. So 2 millimeters or less takes about a week to pass, and about 97% of patients are going to pass that. So if it's really tiny, those punctate stones, you're not worried at all. I think in 7 years, I've taken one patient to the OR for a 2 millimeter stone that didn't pass. So they pass. Stone size around 3, again, they pass. I mean, a little bit less common, but they're going to pass. The 4 to 6 range is that flip of a coin. These are the patients that you're going to send home for trial passage, but you're really going to keep a close eye on them because it's really like 50-50 for that. And then when you get to the 7, 8, 9 millimeter stones, that's when I start to worry they're not going to pass. 7 or above is my thought process for thinking about scheduling the OR. So what I typically do for those patients is I'll get them on, if they want to try to pass it, and they have a big stone, I say, your chance is low. They said 1% here, but they're counting them all. It's not that bad. I mean, like a 7 millimeter stone, it's probably a little better than that, but it's unlikely, maybe like a 20% chance of passing. So I tell them it's unlikely that you will, but not impossible, especially if they've passed large stones in the past before. So I book them for the OR at like the 2-3 week mark, give them a few weeks to pass it. And then that way they're scheduled. If they didn't pass it, we can move ahead without having to kind of start over in clinic and then find the OR time. When can you wait? Next month or next year? Non-obstructing stones can always wait. They're never urgent. Again, stones that are 4 millimeters or less that are really expected to pass in reliable patients, they can follow up in a month. You cannot assume the stone passed if the patient did not collect the stone. So I make all my patients strain their urine and bring the stone back to me so I can visualize it and ensure that what they think they passed matches up with what I think they should pass. And then I don't require further imaging. But if they cannot do that, and even if their symptoms went away completely, I am going to get further imaging on them. Could be ultrasound, could be CT, doesn't really matter, but you have to get something to be sure they don't have hydronephrosis. There is an entity called silent obstruction where the patient's pain resolves for whatever reason. It's not well understood, but the stone never passed. And I have several patients in my practice with kidneys that they lost that I've seen later when they, went to the ER a year ago, had pain, went home for trial passage, never followed up, thought they passed it. And now their kidney looks like this one in the CT scan with massive hydronephrosis and no parenchyma. So I always follow it up. It might be a little bit overkill. I'm not sure what the number needed to save the kidney is. It's probably not great, but I don't want to miss that one kidney loss. All right, well, next we'll change gears a little bit and do an overview of surgical options. So there's 4 main categories of surgical options for kidney stones. There's extracorporeal shockwave lithotripsy or ESWL, ureteroscopy, percutaneous nephrolithotomy or PCNL, and then lastly, open or robotic removal of stone as like a last chance, last ditch resort when nothing else works, and that's pretty rare in this day and age to do. Shockwave lithotripsy is very useful for smaller single stones that are radio opaque and in thin patients. I said 1 centimeter or lower, that's my practice typically, but guideline practice is if it's in the upper or mid pole, it can be up to 2 centimeters. Lower pole, 1 centimeter or lower for shockwave. Lower pole stones are less likely to clear because of that angle to get up and out the ureter. So you have to have a shockwave is not successful in the lower pole, and you have to have a smaller stone, but you can go up to 2 centimeters in the mid and upper pole. But it is not as successful as ureteroscopy, and I tend to kind of favor ureteroscopy for most patients, but I am happy to do shockwave in the right candidate with a 1 centimeter stone. It works awesome and it's way less invasive. So some of the contraindications are really obese patients. It's not going to work as well. Really hard stones. So I always measure the Hounsfield units on the CAT scan. If they're greater than 1,000, that's been shown to be less successful for shockwave. If they have multiple stones, it's tricky. They would need multiple shockwave sessions, or they could do, or you could split the shocks, but then you're not going to be as successful at breaking the stones up. So I don't like multiple stones for shockwave. Ureteral stones, there are urologists out there who do shockwave on ureteral stones. I don't. I just think ureteroscopy is so successful that I can't justify it. But it's a relative contraindication, but not, it can be done. You never want to shockwave an infected stone, a struvite stone, or someone who's colonized with bacteria. When you're shocking the stone afterwards, so you're kind of releasing all this stone material and bacteria, it's breaking up, and then they have to pass it all. So they're going to have intermittent obstruction while they're passing the fragments. That's expected. So you're basically if they have an infected stone, you're creating a situation where they're passing stones and they're infected, and you don't do stents for shockwave. The stents obstruct, actually make the clearance less, so you don't put stents in. So you cannot, it has to be not infected. That's an absolute rule. The struvite stones are not good for shockwave. There's some controversy about CKD, if shockwaves repeatedly over time damage the kidney, so it might not be a great idea if they have renal insufficiency, and then bleeding is one of the biggest complications of shockwave. So if they need to be on anticoagulation, also not a great idea. I found this Google picture of a shockwave. It looks like she's at the spa. It's like not really how it looks. It's like really more like this. It's not a spa visit. It actually hurts. You can do it awake. We usually don't, though. There's a lot of studies that show that the movement from being awake, it decreases the stone clearance rate further. So I still use anesthesia for shockwave. Okay, ureteroscopy. So this has by far become the most common intervention. It's very low risk with a super high success rate, which is why it's kind of supplanting shockwave. It's the gold standard for obstructing ureteral stones. The success rate of removing and obstructing ureteral stone with ureteroscopy is above 95%. It's really high. You can also do ureteroscopy on anticoagulation. It is a little lower stone free rate, especially if they have a larger stone burden, because you could run into bleeding and not see the fragments. You can miss them, but it's safe. Like, you're not going to cause a hemorrhage or anything. You're not going to need a blood transfusion from doing your ureteroscopy on anticoagulation. So if someone can't come off it or they're really high risk, ureteroscopy would be the best option. Very useful for obese patients too. The ureter's never obese. It's easy inside. It doesn't matter. And also multiple stones. You can treat as many stones as you want. A lot of advantages there. These pictures show what it looks like in the OR. It's a really tiny scope. We use X-ray to watch the ureter scope go into the ureter, and then you're visualizing the stone. You're using a laser to break it up, basketing the pieces out. That's why it's so much more successful, is because you're seeing that you got the stone out instead of just shocking it and crossing your fingers and hoping it worked. Percutaneous nephrolithotomy is the gold standard for stone burdens over 2 centimeters or staghorn stones. It's also a very high success rate, but a lot more risk than the other surgeries. You have to go prone positioning. Well, you don't have to. There are people who do supine PCNLs, but most of the time you're going to be prone. And prone positioning has some risks, especially if patients have lung disease. There's a 5% risk of blood transfusion, so hemorrhage is a real concern. There can be pulmonary complications, the pleura drapes over the top third of the kidney. You're going to have a collecting system perforation or a urine leak, and they also require a nephrostomy tube and an inpatient stay. So this is a much bigger deal surgery. This is like, in my mind, kind of the biggest stone surgery nowadays that we do. It is risky, but it has a really high success rate. It's very satisfying to clear really large amount of stone. Okay, and I didn't talk about open or robotic because it's just so rare, but that's when everything else fails. You can do that. So we'll change gears again now and go on to dissolution therapy and medical explosive therapy. Some of the two most common questions I get: is there something I can take to dissolve the stone? And is there something I can take to help pass the stone? So I'll try to answer these questions. So dissolution therapy, what can I take to dissolve the stone? Well, dissolution therapy is old. This is not a new idea. Dissolution therapy dates back to the 1500s with Michelangelo. Michelangelo was known to suffer from uric acid kidney stones. And in his journals, there's a passage here that I'm going to read because it's just so, I love history, so it's really interesting. He said, as far as they can make out, the doctors say I'm suffering from the stone. If it is the stone, the doctors tell me it's at an early stage and that it is a small one. They have no imaging, so they're just reassuring him. And they are therefore very hopeful. I have been given a certain kind of water to drink, and it caused me to discharge so much thick white matter in the urine, together with some fragments of the stone, that I'm much better, and hope in a short time I shall be free of it. So what was he drinking in 1549? Well, there's a natural spring in Italy called Fuji, and they actually sell their water, and it's a very unique water. It's an oligomineral water, and it's not really very well understood how it works, but it does work to dissolve uric acid stones and to alkalinize the urine. It works so well that if you're an Italian and you have kidney stones, you're actually covered on the Italian health plan to go to this natural spring and take time off of work. So it's still there today. There's actually a bunch of studies that have been done, all like in the 90s and early 2000s, looking at this water. This bottom one is the first one, like from the 80s. It's so cool. But basically, it does work, and it probably, there's some idea that it has some molecules in it that complex calcium ions and cause alkalinization, but we don't really know exactly how it works. So you could send your patients to Italy. So that would be one option. But what do we really have? So alkalinization of the urine can dissolve uric acid stones. So if a patient has a history of uric acid stones or gout, the stones are radiolucent, or the Hounsfield units are low on CT. So like when you measure them, if they're 200 to 400, they're much more likely to be uric acid, and you see acidic urine. You have all of those things. You could think about, is this a uric acid stone? Can I treat this medically? You treat them with potassium citrate, would be the first choice treatment. Although if it's a ureteral stone, I usually don't try dissolution. It takes weeks to months, so it's not really safe. And also you're giving them a lot of potassium. If they're obstructed, that's not ideal. Sodium bicarb is another option, but it can cause fluid overload, especially if they have heart disease. You got to be careful about the sodium with that, but that will also alkalinize the urine. Unfortunately, pure uric acid stones represent only about 5% of kidney stones, so this is not a very feasible thing for most patients that you're seeing. There's also the concept of heterogeneous enucleation, which means you have uric acid stones, and that's your underlying metabolic problem. But then calcium oxalate crystals attach to the uric acid nidus, and you end up with a mixed stone. So if you have that process going on, even if you're like a uric acid stone former, you're going to try dissolution, it's not going to dissolve it because there's calcium oxalate has already formed. So the bottom line, unfortunately, still is that in most cases, there's not something to dissolve the stone. They also need, if you are going this route, you also need a lot of hydration for it to work. But I do have like a handful of patients in my practice that we try it on, usually non-obstructing stones that I'm pretty confident they're uric acid formers, and we put them on potassium citrate and follow it, and have had some success, but it's rare. All right, what about the other question? I think we'll have more promising results here. Medical explosive therapy. Is there something I can take to help pass the stone? So the mechanism, the idea behind this is to relax the smooth muscle in the ureter. Things that have been tried are calcium channel blockers, prednisone, and alpha blockers. And then of all of those, at this point, we're just at alpha blockers. They've been shown to increase stone expulsion rates, reduce time to expulsion, and reduce pain. So yes, alpha blockers are great. There was some controversy brought in a few years ago because there was some conflicting randomized controlled trials, and this big publication came out saying abandon medical expulsive therapy. It doesn't work. And so I'll show you why that is and then my conclusion about it all. This was the study that after we had all these studies that said it worked, all these tons of small studies, and everyone was doing it, this study came out. And it was a great study. It was a huge randomized controlled trial, very well designed, 24 UK hospitals. They had over 1,000 participants. And they randomized them to receive tamsulosin, nifedipine, or placebo for a month and see what happens. And they saw no difference in these three groups. And it was like this woke everyone up and said, wait, what are we doing? Do we need to give alpha blockers to everyone with a ureteral stone? Because we had them. This was like 5 years ago. I think I should put the date in here. But anyway, so everybody was like, wait, abandon this. There was even like a plenary at AUA that said stop doing medical expulsive therapy that year based on this study. So then some really smart people said, well, this doesn't make sense. So they went back and they did this big review article, a big systematic review. And they took all of these studies, including that one, and reanalyzed everything. Said, what is going on here? And in this one, they had 60 randomized controlled trials. They had 10,000 patients for this review. And they had, all the studies had mostly tamsulosin in a control group. And they did find that it works. With alpha blockers, it's like an 80% chance of passage. Without them, it was 64%. So they showed a clear benefit. So, and they also showed a shorter time to expulsion of the stone. So not only does it make it more likely that you're going to pass it, it's less time. That's great. And then they did a subgroup analysis looking at size. When they looked at the subgroups, if the stone was under 5 millimeters, there was no difference. If the stone was over 5 millimeters, it favored alpha blockers. So what's going on here? That UK study, when they went back and looked at it, over 75% of the patients had stones under 5 millimeters. Huh. Their patients that showed up for that really well done study happen to have a lot of small stones, and they failed to show a difference because small stones are going to pass no matter what you do. But these medium-sized stones are the ones that you could really target with Flomax or tamsulosin and help to pass, okay? They did also show more adverse events in the alpha blocker group, mostly allergy and dizziness. So nothing real, I mean, allergy can be significant, but it's usually not with Flomax. So the bottom line is that I think the answer is still yes. I still use Flomax for all your ureteral stones. I think the risk is very low. The patients loved the idea that they're taking something that's going to help them pass it. I still give it even for small stones. You probably don't have to, but I do. But I think the ones that you really want to make sure they get it are the 5-6 millimeter stones, and they're in the distal ureter, because the receptors are only in the distal ureter. You don't have the alpha receptors higher up, so it really only works distally. But if they have a proximal stone, it's going to become a distal stone, so it still makes sense to give it. So I still use it. But if I have a patient who's like having side effects from it or doesn't want to take it or has a sulfa allergy, I don't get too worked up. I'm just like, all right, fine, just stop it. All right, back to our case. So our patient ended up passing his 4 millimeter stone 1 week after being seen in clinic. We sent a compositional analysis. He had calcium oxalate monohydrate. We did a follow-up ultrasound that demonstrated resolution of hydronephrosis. Now, in my rules, that follow-up ultrasound is only needed if he didn't catch the stone. He caught the stone, so I actually, in practice, probably wouldn't have done that. I took a parathyroid hormone and a serum calcium on anybody with calcium stones. It's pretty rare, but you do not want to miss hyperparathyroidism. I had a lady just the other day, took a huge stone out on her, randomly checked it. It was 400. She's having surgery to get her parathyroid gland out next week. So it's important you don't catch it a lot, but you cannot miss it. So now you want to talk to this person about stone prevention counseling. The resource that I use is through the Urology Care Foundation. The website is urologyhealth.org. You go there and you just click on resources, and they actually have two cookbooks that are really cool. They have one that's Urologic Cancers cookbook, and then the Kidney Stone cookbook. And I like the urologic cancer one for anyone. It's usually prostate cancer men who are asked if there's anything that they can do with their diet. And there's not a lot of science behind that, but at least you're giving them something. It's really just like a healthy eating diet, which is no harm. But the kidney stone one is where the really outstanding one. This is a screenshot from the first page of that kidney stone book. And this just summarizes so nicely what they need to do. This is what I spend my time going over in clinic, is this page. How do you fight kidney stones with food? High fluid intake, high amount of fruits and vegetables, low oxalate if it's a calcium oxalate stone. They do not need to follow a low oxalate diet if they have calcium phosphate or uric acid or struvite. Less meat, moderate amount of calcium, and low salt. Those are the bullet points, but the book then has a section on each one of these bullet points in detail, which I tell them is their homework to read, and then it's a cookbook. So it's a really good resource to try to get for your clinics. The Urology Care Foundation does provide them hard copies for free. You just need to contact them, but you can also download it as a PDF from the website. So I added something here. On this case. So this guy, we look back and his CT also had a 4 millimeter non-obstructing stone in the lower pole on the contralateral side. What do we do about this other stone? So non-obstructing stones, should we do active surveillance or intervention? The good thing is there's no right, good and bad is that there's no right answer. We don't know what to do about this. The current guidelines are equivocal, studies are mixed as far as whether it's beneficial to take it out. You take it out, you're introducing them to surgical risk. They're not having any problem from it. It's asymptomatic. You don't take it out, they're going to come to the ER with an obstructing stone. They could have an infection. They could have a kidney injury. So that's what you're balancing. What can you tell the patient? So what is the natural history of these stones? There's a few studies that help us sort this out. There's a Korean study, good one from 2013. They had 350 patients. They all had asymptomatic renal stones, and they followed them for like 5 years. They were reasonably sized, you know, kind of what we're used to dealing with, mean size of 4 millimeters. They found that about 30% of patients will pass their stone, and about 50% will develop symptoms. They usually develop symptoms at about 1.5 to 2 years, and about a quarter of people will need intervention. Another study was looking just at lower pole stones in Turkey, but it was pretty similar in that 20% needed intervention. So it's about the 20-25%, and the indications for intervention in that study was stone growth, development of symptoms, or recurrent UTIs. So I tell patients, you know, it's kind of like a 50-50 of whether this is going to become symptomatic in the next few years. And you might, and it's about a 25% chance that you'll just pass it on your own without needing surgery. Now we have a new study that just came out in New England Journal of Medicine. That's a fascinating study to me that really helps inform this topic. It's a little bit different of a question, but it has a lot of information that's useful. So this, Matt Sorensen, he's a program director at University of Washington, led a multi-centered trial. Took him a long time, it was like 5 years. And they took all their patients who were scheduled for surgery for a primary symptomatic stone, and then they had a secondary asymptomatic stone. So like they came in, they had a ureteral stone that was obstructing them, and then they had a small asymptomatic stone on the other side, or even they had the same side too, and they accounted for all that statistically. So they ended up with 75 patients that they randomized. They said half of you we're just going to take out the symptomatic stone, and the other half we're going to take out all your stones. And because previously this has not been randomized, there are studies showing that maybe you should only take the symptomatic one out because you increase operative time, increase risk to get the second one, go on the other side. Like, should you really be doing that? That stone wasn't even causing a problem. So it's a big question. And then they looked at the primary outcome of relapse. They defined relapse as an ER visit due to stones on the same side as asymptomatic side, or secondary surgery on the asymptomatic side, or growth of the stone on CT. So the bottom line is like, you know, that relapse means that they had a problem with that asymptomatic stone side in the future. What did they find? 63% relapse in the control group and only 16% relapse in the treatment group. So a huge benefit of taking out that asymptomatic stone. They're down to only 16% chance of showing up in the ER with a problem if you take it out versus 63%. And this is over like 2 years. The time to relapse was way longer. It was 697 days. For those 16% of people who relapsed in the treatment group, they're probably relapsing with new stones at that point because they're taking up 700 days for them to come back. So those are new stones. So they're basically saying this study gives us the first evidence that treating asymptomatic stones at the same time as your ureteroscopy for a symptomatic one is beneficial. And then the cumulative incidence of new stones in both groups was similar, which is also super interesting to me because it doesn't, whether you take it out, they're still going to form new stones, and it's at around 40%, a little better than the previous data, around 50%, but you know, they can get new stones, but that's not going to change no matter what you do when you treat them. But you can at least prevent them from coming to the ER for the asymptomatic one. So the bottom line is we still need more studies. It has to be a shared decision-making conversation. If the stone is less than 6 millimeters, I tell them there's around a 20% chance of spontaneous passage in 5 years and about a 50% chance of needing intervention in 2 to 5 years. That New England Journal of Medicine article that just came out, it shows us that if you remove the stone, you prevent ER visits and you prevent subsequent surgery. That's great. I've been already telling my patients that. And telling my patients that's the reason to take it out if it's asymptomatic is you'll be less likely to come to the ER in the future and need a surgery urgently. It still doesn't quite answer the question though of what do you do with an asymptomatic stone and they're not going to surgery for another one. It's still a decision they're going to have to make. So I basically put it in the words of like, you either going to take care of this asymptomatic stone in your own terms, where you schedule it and it's elective and you do that, but then there's a chance you're having unnecessary surgery because maybe you never would have needed it treated. But you could also, the other hand is you're taking the risk that you need that surgery urgently, and it's usually the day you're leaving for vacation. So, you know, usually if the patient, I'll lean towards kind of pushing them towards intervention if they're young and healthy, because all these studies too are looking at like 3 to 5 years. Like if you've got a 30-year-old there, you know, that stone's going to be a problem at some point in their life. So they just got to decide if they want to deal with it when they have to deal with it or now. Also pilots. So pilots can, the FAA, you cannot fly a plane if you have any non-obstructing stone. So they all need to be treated. They know that though, the pilots will tell you that. They know that they can't fly. And then anyone who, I do ask about rural travel or like people who do a lot of hiking. You know, I don't want people going hiking in the Himalayas with non-obstructing stones. Those are the people I would definitely push towards getting them out. I have one lady who does crazy traveling. She's so cool. She's like 70 and fit and retired, and she like does African safaris, and she's always all over the world. And then, so I operate on her like, you know, every 2 years to get her non-obstructing stones out. She does not follow a stone diet, but we just get them out every time she has a big trip coming up. So if you're not going to intervene though, then you're going to do surveillance. You do need to do surveillance. You can't just let them go. You want it, what you're looking for on surveillance is mainly stone growth. Stone growth is kind of a soft indication to move ahead with surgery because it's just going to keep growing. It shows it's metabolically active. You don't want to let it get to that threshold where they need to have a PCNL. So you want to catch that and then intervene. Or movement. Movement concerns me. If I'm watching a stone and it's in the lower pole on one scan and then the upper pole on another scan, they're, I think, at way higher risk of acute obstruction, and I would definitely intervene on that. What imaging to use for surveillance is something that's currently driving me crazy. I maybe want to do a research study on this. It's ultrasound is good for direct comparisons, but it's not great for growth because I already talked about the limits on size. So it's tough. But if you have ultrasound to ultrasound, I think that can be helpful. But ultrasound compared to CT is tough. So what I typically do is I'll do ultrasound as much as I can and then periodically throw a CT in there so I can put the CTs next to each other and really see if it's growing or changing at all. Usually about every 2 to 3 years, I'll try to get a CT scan. I image them every 6 months initially, and then if it's stable for a year or two, depending on how concerned the patient is, we'll just go out to annual. All right, so just a little trivia for you guys for the last few minutes. Got to tell you about some famous stones. I can't resist. So William Shatner, he sold a kidney stone that he passed in 2006 for $75,000, but he did donate the money for Hurricane Katrina relief. And at Loyola, the patients are not allowed to take their stones home. They sign that in their consent. And I always wonder if we had someone like William Shatner, can we make an exception? Like if this stone is worth 75 grand, we got to help someone out here. Gene Simmons tried to do the same thing, but he only got 15,000. Again, Michelangelo, told you guys I love history. So he had this long history of gouty arthritis and recurrent uric acid stones. He did die from stones too. He died from renal failure, but probably from stones. He had evidence of obstructive nephropathy in the journals. But because of this, he demonstrated a major interest in art. This is from the Sistine Chapel. Everyone thinks this is actually a kidney. And there's a ton of examples in art history of him drawing reniform type art. Benjamin Franklin, he had a large bladder stone. It left him bedridden and confined to his house for the last year of his life. And he actually invented the flexible urinary catheter. They were all metal previous to Benjamin Franklin's invention. And he did it to help his older brother, who also had stones in retention. There's also reports that sometimes he would have to go stand on his head to be able to urinate to get the stone to dislodge out of the prostatic urethra. So it wasn't a lot of good options, I guess, back then. Thank you so much. This is my email. I'd be happy to take any questions.
Question. So I had a young patient with a large stone. I think it was over 1 centimeter. And he called asking if he could go on some roller coasters and would that affect the stone from obstructing versus not obstructing? What are your thoughts on that?
Awesome question. Yeah, I do think that we don't have study. Well, there is one study on roller coaster. But it makes sense to me that a roller coaster will dislodge a stone and cause it to pass. So I would caution patients on roller coasters who are watching on obstructing stones on. But there was a group, I think it was University of Florida. It was one of the Florida schools where they took a model of a kidney. It wasn't a person, but it was a model that they created, a stone passage model, and they put a stone in it. And they rode it on Thunder Mountain Railroad in Magic Kingdom. They rode it with the model. And they did all these different sizes of stone and things like that. And yeah, it caused it to pass or caused it to dislodge and move around for sure. Not super accurate, but it got published. But I do worry about roller coasters. Yeah.
When you treat stones for like a recurrent UTI patient, what's your threshold on that? Is it 2 in a year? Is it something you can't treat? Is it a size of the stone? Kind of
Yeah, great question. So recurrent UTIs are tricky. If the patient has stone forming organisms, like a struvite type stone, so Pseudomonas, Proteus, Klebsiella, and some E. coli, which E. coli is so common, so that one's a little hard. But the other 3 classic ones that I'm going to treat every single stone they have, because I think that's a very high likelihood of association. Now, if it's E. coli or not one of the 3, Enterococcus or something else, then that's a little bit of a tougher conversation. If they have no other risk factors, I probably still treat the stone no matter what size it is. But I'll counsel them that the best data we have is about a 50-50 chance of this actually being the cause of your infections. Manoj Manga at Cleveland Clinic did a study looking at this, and that was the end result. I don't remember all the details of the study, but I remember that end point to counsel patients on is that he took all patients with recurrent UTIs, I think it was 3 or more a year in that study, took their asymptomatic non-obstructing stones out, and half of the women's UTIs cleared, and half of them did not. And that's my experience too, I think. It goes parallel anecdotally when I do this. And that's what I counsel them. I say, you know, we'll take it out. I say there's other benefits to taking it out, like we already talked about, less chance of ER visit, less chance of acute obstruction. So it's not like a lost cause if we don't fix your UTIs. So I do end up taking them out on most people with UTIs because they're so desperate for anything to fix it. And it could work. It definitely could work, even small ones, because sometimes there's one. I've had some patients where I think it's not going to work. And then I get in there and the stone's like 3 millimeters, but it's like plugging the papilla. And then I release it with the laser and like cloudy crap comes out. And I'm like, oh, wow, it's maybe actually going to work. So, you know, I don't, at this point, since I've learned that, I don't rule anyone out based on the size of the stone. I'll do it for UTIs on anyone. So I guess 3 or more is probably my threshold, I guess. If it only had one, I'd be like, let's see what happens.
So for patients saying you have family history, stones, is there a role for doing just screening at any point?
No, I mean, there's nothing at least like officially recommended. I think for that, what I would think about doing if the patient's worried and you're like seeing them for another reason is get urine. And if they don't have hematuria, the chance that they have a stone is so much less likely. So I would screen just with urinalysis because it's so easy to do. Because there's nothing published or recommended as far as like imaging screening for that purpose. And you don't want to open yourself up to like incidental findings that you got to deal with. All right, great. Well, thank you guys so much. I really appreciate it.